better title might be social scientists broadly publishing for health audiences or in health journals, something like that. My name is Jesse. I'm a senior research manager at JPAL North America. I'll introduce just a little bit about us and why I'm here, where we're coming from. But JPAL is the Abdul Latif Jameel Poverty Action Lab. We're a research center based at MIT in the Department of Economics. And our mission, as the slide says, is to reduce poverty by ensuring that policy is informed by scientific evidence. We do that through research, policy outreach, and capacity building, training events and resources, training events like this one. We specialize in randomized evaluations. So I was in the pre-analysis plans for experiment session a second ago. And as a research manager, my work involves a bit of my own research, a lot of supporting researchers in our network to implement their experiments on the ground, and capacity building work like developing resources and doing trainings, which is some of the content that this is based on, with the goal of kind of making it easier for folks to conduct RCTs and use evidence, things like that. This is our map slide. I'm based at JPAL North America. This might just be helpful if folks have some conception of JPAL. We have 7 regional offices around the world. Mostly we're focused on development economics research in low and middle income countries, with one exception, or sort of one exception, one maybe more. JPAL North America, we're based in Cambridge at MIT. We focus on doing similar work, but in the North America region, primarily in the US. Each dot on this map is an evaluation that we've been involved in some capacity. The colors all represent different sectors. We really define poverty alleviation really broadly, and we work across a variety of kind of policy areas. One of the biggest areas of focus for JPAL North America is healthcare delivery, which is what I'm going to talk about now. The US healthcare system faces a myriad of problems, as I'm sure everyone's well aware. We really think that rigorous research is crucial to that mission of making healthcare more equitable, more effective, more just, things like that. Through this initiative, we've funded and implemented, I think 52 studies of some kind. And we really want to try to spur more research in this direction. The medical profession has obviously long recognized the value of randomized trials, and we're hoping to do the same for healthcare delivery and health policy research. Basically, all of this is just by way of introduction of what I'm here to talk about, which is that we've done a lot of research on the intersection of social science and health policy, where our audience is often policymakers, practitioners, rather than just other economists and social scientists. And a lot of this work has ended up being published in medical journals. And so I'm working with a bunch of economists, and we're kind of often publishing outside of our field, and we've learned a lot about how that works and what we've gotten right and gotten wrong. And so this is kind of, I guess, a shift in focus a little bit from maybe best practices to like realistic practices, and how do we actually get things through the publication process in an unfamiliar world for some of our folks. So this slide's really just a reference. I'm going to come back and talk about some of these studies, examples of published work in medical journals. But I guess just to motivate this a little bit, medical journals are nice. They're read widely. They generate lots of press. They publish quickly. They publish weekly in a lot of cases. They're read by practitioners and policymakers that we might care about. They often might care more about the topics that we're studying than an economics journal. So this is an example of a paper that I was involved in. I was the research manager on this project. It's healthcare hotspotting, which is an evaluation of a care coordination program for complex patients with high costs and high needs and frequent hospitalizations in Camden, New Jersey. We did an RCT of this program. Turns out it was ineffective at reducing hospital readmissions. This probably wouldn't have been a good fit for a top economics journal, but it found its way into the New England Journal of Medicine and received a bunch of coverage, like this example from the New York Times here. So a lot of this research that we're doing, even though I'm working with a bunch of economists, is a good fit for medical journals, and there's some nice features of publishing kind of outside of our economic space. But one thing we've discovered is that there's a lot of rules, and there's a set of expectations for publishing that aren't always clear until you try to do this, and there could be some real consequences for not following the rules. So I don't know, this is kind of fuzzy, but this is an email that my boss, Amy Finkelstein, got from a colleague of hers that says, we have a new paper on the effects of clinical health outcomes and health beliefs. We submitted it to the New England Journal of Medicine. We were summarily rejected because the AEA RCT registry is not a WHO/ICMJE qualified registration. We also have a clinicaltrials.gov registry, but we added this after trial registration began. So they're doing all these, good open science kinds of things, and they're getting rejected for what seemed like a technicality that we weren't aware of at the time. So if folks are, I know everyone's coming from different places, but for folks where this kind of vaguely applies, social scientists, healthcare research, aging research, my goal here is really to just kind of give a bit of this background, things to think about, kind of reading the recipe before you start so that you don't make the same mistakes that our colleagues made. This is not the only email we've received like this. And so these, I said, there's a set of kind of expectations here broadly, and I'll go through these, a little more detail, but that's pre-registering your trial before things start, before you've enrolled anyone. Know that you're going to be, writing up this pre-analysis plan and your trial protocol. You're not just writing it for your own sake or for open science purposes, but you're also going to be submitting that with your paper. And then when you go to write up your paper following the kind of expected reporting guidelines for when you do that. I'll talk, through all of those steps. That's broadly, there's things to do in advance, and there's a certain way of talking about your research. So a little bit more kind of motivation for this. So most medical journals are members of this thing, the ICMJE, which is the International Committee of Medical Journal Editors, and they follow its recommendations and requirements for publishing. And as the previous email showed, they can really be sticklers for this process. And because there's this consortium, there's a lot of buy-in across the field, which is great. It's standard, but it means that, if you get rejected somewhere, it's maybe hard to find another way to get that out if you didn't do it the right way. I would say that in general, all of these rules are really good. They're motivated by, real concerns and desire for research transparency and standardization. So this supports, I think it's in service of transparent open science. It's motivated by trying to really correct problems in the past. So a lack of standards in the past, concerns about publication bias, concerns about not just publishing certain studies and not others, but underreporting of important details within a study, things like harms or adverse events that may have occurred that weren't, talked about. And I think trying to account for what we might think are, really important incentives in the medical field, things like where you have drug, developers they're the ones funding trials to get their drugs to market, want to kind of guard against the incentives that sets up. The other thing I think, and this is more just the consideration of the audience, that these journals are read by practitioners, by doctors, often without real research backgrounds, and the results in medical journals have the potential to kind of change clinical practice. And so there's a lot of, the goal of some of this standardization is to make sure that things are easily read and understood and not overinterpreted or misinterpreted by, this audience that can have a real, effect on what happens in the real world by virtue of reading your study. And as I've said before, previewed with the email, a lot of these requirements for publishing mean, action before your study starts. So you really want to know what these things are, at this point. One thing I'll say is most of this content, I would say, is relevant across medical journals. It's broadly our experiences in randomized trials. I'd say it's broadly applicable to either certainly clinical trials in medical journals, and I think there's clinical trials or things like clinical trials in other fields. There's some applicable stuff here. And even if you're doing observational work in this, area, a lot of these concepts, not all of them, but a lot of them will still kind of carry over. So some key steps. So I'm trying to make this bigger on my screen so I don't have to keep turning around. So key steps for publishing a randomized evaluation or some sort of clinical trial or clinical trial-like thing in a medical journal. Said this already, but before enrollment starts, registering that trial in the right place, an ICMJE compliant registry. Not doing this can really make it hard to publish in most medical journals. What's an ICMJE compliant registry? There's a whole list. You can go on their website or on the WHO website. Actually, now they are the keepers of the list. but for practical purposes, that's clinicaltrials.gov. It's not some of the other places that you might have thought to put up your pre-analysis plans. So an OSF page, the AEA registry, in economics that JPAL is involved in, your GitHub page, your personal website, these things are not, they might be good. You maybe have a timestamped version controlled thing, but it's not an ICMJE compliant registry. So maybe a technicality, but it's an important one to be aware of. The second thing is, along with your registration is crafting a trial protocol and statistical analysis plan. Talked a little bit about that already. I'll say just a little bit more about that today. And then after your study, drafting your manuscript according to journal requirements and reporting guidelines. There's a standard way of doing things in medical journals compared to social science journals. Articles are short, often very short, 3,000 words or so. They have a standard series of steps you need to go through. The acronym to know, and we'll talk a little more about this, is CONSORT, which is the Consolidated Standards of Reporting Trials. And there's lots of offshoots for different, kind of sub disciplines. So there's a CONSORT, there's the regular version, there's a version for clustered trials, there's a version for social science research, et cetera. But just be aware that there's a particular way of doing things, and that might be unfamiliar. And then when it comes time to actually submit your paper and release it in the world, you want to keep in mind embargo and preprint policies. Journals really like being the ones who get to release these findings into the world. So there's often requirements about not sharing those on your own in advance that you want to be aware of. This is an area where there's, I think, largely because of COVID and a desire to get research out as fast as possible, some changing norms, but most journals still have some sort of embargo, which I'll talk about as well. So I've split up the bulk of this into kind of 3 stages: before, starting your study, during it, and after. So before, we've talked a little bit about, but if there's nothing else that you learn here, register your trial before enrollment begins and do it in the right place. And then most other problems are fixable later on. This one's much harder to fix. More specifically, if your study meets the definition of a clinical trial, researchers need to register it before the first participant is enrolled. And the ICMJE defines a clinical trial in a particular way as a research study that prospectively assigns human participants or groups of humans to one or more health-related interventions to evaluate the effects on health outcomes. There's kind of 3 parts. Prospectively assigned, so that's randomization, obviously, but even if it's not randomized, if you're doing something where you are in control of what happens to your subjects, anything not observational, that counts as prospectively assigning. That's a clinical trial in some form. Health-related interventions is defined really broadly, so types of things that social scientists do, even information campaigns or nudges or text messages. If it's vaguely health-related in some aspect in terms of subject matter, it counts. It's not just like injecting people with things. Lots of stuff in that category. Health outcomes is a little more narrow. So there's this kind of exception to this pre-registration rule that if the purpose is only to look at the effect on providers, doctors, things like that, so say they're like knowledge or attributes or attitudes, and not something that's downstream of that, that's actual health outcomes of patients or community members, the ICMJE says you don't need to register that in advance. That's an exception. In practice, I would say that line is often really fuzzy. So I wouldn't bank on that. I would still register it in advance if you think the thing you're doing is, vaguely a clinical trial. If you have any interest in potentially publishing in a medical journal, even if you're only looking at, practitioners and not their patients, I would still err on the side of caution and, do it. But this is officially, there's this distinction. It's described somewhat inconsistently. Some people might say, well, if you're doing that, it's not health outcomes, it's not a clinical trial. The way that the ICMJE phrases it, that it is a clinical trial, it just doesn't need to be registered. That's somewhat inconsistent with their own definition, but this second line here is directly from their website. So that's their rule. You can try to see if you can figure this out for yourself. This is, I don't know if people can read this slide. It's a little bit light. This is an audience participation section. So I'll read it out and folks can see what they think. So a large national study aims to determine the effectiveness of reducing sedentary classroom time on children's physical activity levels, measured via questionnaire and accelerometry. Schools will be randomly allocated to the control group, usual practice, or to a multifactorial intervention that includes provision of standing desks and teacher education to reduce sitting time in class. So I guess by a show of hands, is this a clinical trial? People think yes, raise your hand. Anyone say no, not a clinical trial? All right, so it wasn't everybody, but no one's saying no. Yeah, this is a clinical trial. The study involves human participants. They're in clusters, they're in schools, that doesn't matter. They're going to be prospectively assigned, again, in clusters to an intervention, and it uses a health-related behavioral outcome measures of physical activity. And this requires pre-registration. So the health-related behaviors are measured at the level of community participants, the school children. In contrast, here's another study. This study will evaluate whether educational intervention for physical therapists improves the therapist's adherence to clinical guideline recommendations for people with osteoarthritis. They're going to be randomly assigned to an intervention group, which is a 2-day education program, or the control group, usual practice. Outcomes will be measured after 6 months by auditing treatment notes to determine the proportion of therapists who prescribe strengthening exercises for patients with osteoarthritis. So this is also a clinical trial, but technically, no, this does not need to be prospectively registered because the health-related outcome is measured at the provider level. This is from a published paper that tried to suss out this fine line. So this is a kind of approved answer, but the ICAMG will not answer this question for you. If you have a question, you can't ask them. It says that on their website, don't ask us. So this is like maybe interesting to know, but I would certainly hedge your bets and just register your trial. Sometimes that is harder, in practice. So not every evaluation that you're going to do is going to meet this definition. And there's sometimes where you might not, be able to meet that pre-registration requirement, or not understand if it applies to you. So a couple of actual exceptions, or just ways of handling situations. If you're doing secondary analysis of a clinical trial, so you did your first clinical trial, you registered that one, hopefully on time, you published a paper, now you're doing more analysis, that's the same clinical trial. So you don't need to register that separately. You just reference the same number from the previous one. You can upload a second pre-analysis plan to the same clinicaltrials.gov entry. You don't need a separate registration. If you're doing analysis of a clinical trial that someone else implemented, that's also secondary analysis. This comes up for our group a lot because so we do randomized evaluations. Sometimes we design those on our own. Other times we like to take advantage of experiments that other people are doing, maybe not actually for research purposes. So, a government agency might decide to, run a lottery for a program because it's a fair way of allocating some limited resource. That, meets the definition of a clinical trial, but we didn't start it. Maybe they're evaluating it on their own. Maybe they're not. Either way, from our perspective, that's a clinical trial, but our research is secondary analysis of their trial. So if they have a trial registration of their own, we can reference that number. If they don't, which is often the case in these government programs that are not set up for these same kind of scientific standards, in those cases, we end up usually registering it ourselves, as this is what we're planning to do for our analysis. Because of how we find out about these things, we often don't meet that cutoff for pre-registration. Like something's often out in the world already before we do that. We just, so far that hasn't been a problem. We note that this is secondary analysis of someone else. If there isn't a trial registration, we'll create our own. And then evaluations of healthcare providers, which we've already talked about, is this kind of third exception category. What does the registration actually look like? It's basic information about your study, similar to what would go in a pre-analysis plan or a trial protocol. In the ICMJE requirements, there's like 24 required fields that all of these registries need to accommodate. I'm not going to go into those in full, but essentially there's some identifying information about your trial, a title, a summary, the country it's in, funders, the sponsor. This might be an familiar phrase for folks outside of the clinical world, but this is essentially like the organization, which could be a corporation, that initiates the study. They might be the responsible party for it, or it might be that the investigator, you, the researcher, initiated the study, in which case that sponsor is you. But that's like because this is kind of set up for the kind of imagined case of like a drug trial, there's information like that. Study design elements. So the experimental design, is it randomized? What are the interventions, inclusion, exclusion criteria, target sample size, outcomes, things like that. And then there's, a status type of category. So does it have IRB approval yet? From where? What's the enrollment plan? Is it currently recruiting? Do you have results yet? You don't at this stage of pre-enrollment, pre-registration, but at some point this will be updated to like the current status of the study. And this is a place where you can post your results later in kind of a populated app kind of way. So it's basic information that you would need at the start of your trial before enrolling, and probably would have already. And updates are timestamped, they're version controlled, they're given a unique identifier, so you can point to this clinical trials registration number as you go forward with your trial. So pre-registration, number one important thing. Another thing you want to do in advance of your study is develop a trial protocol. This is something you're probably doing already, but maybe not in exactly the form that you might need or might have thought about if you were thinking of like submitting it to someone. So a trial protocol outlines the objectives, the methodology, your study procedures, your statistical analysis plan, ethical considerations for a study. This is the same thing if you're doing human subjects research that you would be submitting to an IRB to get approval for your study. But medical journals are going to want to see this submitted at the time that you submit your manuscript. And so you want to plan ahead for that purpose, not just for satisfying your IRB. So you can start with the form on your IRB website. You can go through their questions, but you might want to start a little bit from first principles and from a checklist that this field has put together. The acronym to know for that is SPIRIT, the SPIRIT reporting guidelines. This is, if I can read the little thing, standard protocol items, recommendations for intervention trials. They love acronyms. That one doesn't tell you much, but that's the standard of all the things you might want to hit in this trial protocol. There's additional guidance for specific fields. So Sean Grant, who was here on Zoom, I believe earlier today, he has a working paper that's a proposed framework for doing this in social sciences that's a little more tailored to that context. But if you go to the SPIRIT website, it looks like this. There's a checklist of things with some example text, some explanation, and you can kind of run through the checklist there and make sure everything is covered in your protocol. As part of this protocol, and some people think of this statistical analysis plan or your pre-analysis plan as a separate thing. Sometimes it's thought of as part of the protocol. That doesn't really matter. But you also want to develop your statistical analysis plan. We talked a lot about this in the last hour, so I'm not going to go into a lot of detail. This is, again, most commonly in the medical field kind of presented as a checklist that you should go through. We saw alternative, at least in the room I was in, an alternative way of doing that in the previous hour, which I think is really cool. I really liked. I don't think these are contradictory things. I think so long as you're, covering everything they want covered, this is not something where the order really matters or where the format really matters. But you want to make sure that you're, comprehensive for kind of what they're expecting to see. You can always do more. You can add on some, declare design type stuff, even if that's not in their checklist. There's no reason that can't be the case. Like I said, we talked about this already. I do want to point out a couple things that, at least in my experience and in the experience of folks in the JPAL network who have come to us with their problems, have found is a couple of things that are potentially unique to the clinical trial world that are worth knowing about and worth doing right. So one thing is specifying a primary outcome. I'm not sure how common this is across the social sciences, but this is very common in the medical literature and clinical trial literature. Broadly, you might have 20 outcomes in your paper, but you're going to pick one, maybe two, but really just try as hard as you can to pick one as your primary outcome. And that's something that you're going to pre-specify as the thing you care the most about. This is what you're going to fall back on if you have mixed results. You're going to say, well, it did this on the primary outcome. This is something you want to be very well powered to detect. You want it to be something that you can measure in the timeline of your study. This is not, if you're doing something on, cardiovascular disease, this is probably like a blood pressure measurement that you can take easily, that you can get. This is not waiting for heart attacks to occur or death to occur later on. More likely it's a more proximate outcome. But either way, picking something that you think is of primary importance, the main objective. You can have other things, but picking that. Describing your plan analyses, like we talked about in the last session, two things within that people don't always do, that I've seen medical journal editors care a lot about, are how you're going to handle missing data and your plan for multiple hypothesis testing. These are things that we've personally been, I guess, dinged on and forced to do things differently in our papers than we would have been otherwise had we simply had an example of how we were going to do this. Missing data you should expect to have. I've got an example that I'll cover a little bit later, but we had a study where we had enrolled and randomized 800 people. We then used administrative data to find their outcomes. So we matched these people to hospital discharge records. We matched 782 of them out of the 800, which I thought was pretty good, over 95%. The journal came back to us and said, well, what about these other 18 people? You need to account for them in some way. And so we were required, I think, to add a multiple imputation analysis to show robustness to making up answers for these remaining 18 people, which I know a pre-analysis plan is not where you're supposed to fall back on and say, like, look, we said we were going to do what we talked about last hour, like we said we're going to do it this way, we're not deviating. It would have been helpful to have something and not to be entirely at the whims of the reviewers and editors for how we handled this thing that we didn't think was going to be a big deal that they thought was a very big deal. Same thing with multiple comparisons. Similarly, had no plan for what to do in this particular paper. This is for the folks in the room earlier. This is the thing where we underdid it and then overdid it in the second paper, pre-analysis plan. We had no plan for this. So they said, you can talk about statistical significance for your primary outcome and not your other outcomes. And that was, an editorial decision that was made on our tables and figures that I think could have easily avoided had we just given them really anything at the stage of the pre-analysis plan. So that's two things I wanted to call attention to. I raised this also as a question in the last session, but when to finalize your statistical analysis plan? Unlike the kind of very strict and unbending rule about pre-enrollment trial registration, there is no comparable requirement on the statistical analysis plan. Really what the journals want is just a plan written at any point. Even if it wasn't pre-specified, they just want the detail of what is done. But you will give yourself more freedom and more credibility and more ability to use causal language. And it's also in the service of, open and transparent science if you do this earlier. A couple of kind of points where you might consider locking this down and considering it finalized and pre-registered might be before the launch of anything at that same pre-enrollment stage when you're registering your trial, or at some other kind of checkpoint before things are revealed to you. So maybe before data collection, if your intervention has been run, but then the survey is going to be fielded or you're going to acquire the data at some point before that survey goes out, you can register it, or prior to the data analysis. So maybe the survey is back, but you haven't seen it yet. You haven't run any code on it. You can also, that might be your last kind of checkpoint where it's like fully prior to anything that you've seen. And I think the balance here is, do you know enough about what you're doing at these various stages to be able to specify this stuff in sufficient detail? Where do you put this? If you post this on your trial registry, it's going to get timestamped so you can say, look, we publicly archived it at this point in time before such and such thing. So those are the big kind of pre-RCT or pre-clinical trial, pre-whatever prospective study you're doing. While implementing the RCT, I don't think there's not so much that's specific to medical journals here, except to note that despite the short length of most medical journal articles, they want a lot of detail about very specific like mechanical steps in your methods section. So you want to be able to keep track of all that. Your opportunity to keep track of all that is during your study so that you can then talk about it later. So two things in particular, tracking the flow of participants through your evaluation. This is something that you will need to report on in significant detail when it comes time to write up the paper. I mentioned Consort, this consolidated standards framework, which has all the steps in the reporting. This figure on the right is known as the Consort flow diagram, and this is typically figure one in every clinical trial. This shows how people progress from the start to being in your analysis. This comes from that healthcare hotspotting study that I mentioned earlier, and you can see it's tiny, but at the top, we had 1,520 people that were triaged. They were assessed in some data for potential eligibility. Most of those were deemed eligible. Then we went out and tried to consent those folks. We consented 809 of them. We then excluded a couple of them. So 800 people underwent randomization. That's our full trial sample. We assigned them to treatment and control. We showed who was matched to that administrative data that I mentioned and who ended up in our sample at the end. One thing I like about this example is we were able to track a lot about patients prior to randomization, which isn't always the case depending on your study design. But in this case, I think it's useful for other researchers because it gives some sense of both like the effort involved. So if you need an 800-person sample, how many people do you need to like have in the potential column? And also maybe gives some sense of generalizability, maybe depending on what you know about these people. You have some sense of how the sample was selected down into the folks that were analyzed. One thing to note here is this is something where the journal, the editors asked us to provide more information and we actually were able to do it, but in this did not provide consent on the right here. Originally, we just had 633 people didn't provide consent. The editor said, well, what happened? What did they do? Why didn't they provide consent? And we had to go back, we looked at our notes, but fortunately we had this information and we could say, well, some of them, actively declined to participate. They, we told them about the study. They said no. Other people, like we pitched them on the idea. They said, I'll think about it or something. And then some people weren't able to provide consent. So in this particular study, we were recruiting people while they were in the hospital for a program that was going to start post-discharge. And so the 79 people that were unable to provide consent, like we went to their room, they were sleeping or they were being seen by a doctor or something. So it's ambiguous. We don't know if they would have consented or not. Well, we weren't able to get it. We moved on to someone else. That's detail that we didn't think to put in, but I do think it's useful. And it's the kind of thing that someone might come back and ask me about. The other thing to keep track of is the mechanics of things like randomization. And this got brought up before. I think this is a good open science thing, not just randomized, but how what you'll often see in the methods section of a paper in a medical journal, despite the short length of those papers, is a tremendous amount of detail of the narrative of like who walked this little piece of paper with random assignments all around the hospital and how did it work. It's honestly like very stands out as like a large amount of information. The story that's told about small little steps. So here's one example. This is a massive block of text I don't expect you to read, but that's kind of the point. This is from one of the articles that I mentioned on the first screen. It's from a study of Medicaid eligible mothers and financial support to increase caregiving for preterm infants. It was published in the Journal of Maternal Child Health. And it really tells the story with all these characters and all these detail about how randomization worked. It says, we stratified women by whether they had a single birth or twins. We used a computerized random number generator to conduct the one-to-one randomization. The research assistant generated the allocation sequence in advance. 2 study team members, we got new people here in the story, trained in recruitment and enrollment, reference this spreadsheet, blah, blah, and it goes on to explain how we're confident that no one tampered with this and no one knew, was able to mess with the randomization sequence. It's not quite the same as like giving them the code, but this is the kind of level of detail that is often expected on these kind of methods topics. So it's the kind of thing that if you didn't keep track of during your study, you might not be able to go back and recreate. Yeah. Yeah. So it's
kind of ambiguous about how
right. Yeah, in some respect, I mean, I was thinking about the kind of the approach that we were discussing in the last hour in this, code-based, and often I've wondered or struggled, like, can we just send you the code rather than trying to describe this in words? And yeah, lots of things could be consistent with this. Actually, like what's being done on the computer is usually the part that's like most ambiguous in my experience. What the journals seem to care about, or at least what authors seem to think the journals care about when they write these things up, is like the tampering possibility. So it's more the narrative of like who knew what when. Thinking about the context of a clinical trial where like blinding people to outcomes and stuff like that is a primary concern. Often stuff like that is like either of less concern because a social science intervention might be informational, where you want people to know what group they're in, or it's just not possible in some context. But that's the context in which these like guidelines came from. And so I think that's why the emphasis is there rather than on like, I think if you stratify it, that should be in there. But if you, I don't know, trying to think of what else maybe wouldn't end up in this kind of thing, like you're not going to see a lot of differentiation between like a simple randomized thing or some sort of, permutation randomized. Like I've not seen that super detailed usually. But yeah, I think it's mostly the kind of human behavior aspect of randomization, which is often, at least like for us on the, working with implementing partners to do this kind of work, often something that we're concerned about too. So we do tend to end up getting a lot of this data. We want to be able to verify if like, a nurse who's not a study team member is doing this, that they're doing it the way that we specified. So I think sometimes researchers share the same concerns as journals, but there's obviously different ways of doing this and lots of procedures that might be consistent with even this large block of text for sure. All right, so there's probably more to keep track of. You should keep track of, you should monitor the implementation and quality of your study broadly, but that's not specific to healthcare research or to publishing in medical journals. The randomization block of text does kind of stand out as something to keep in mind, as well as the participant flow. Okay, so you've done your study now, you've pre-registered it, you're planning to send it to a medical journal. You want to first kind of prepare your manuscript with the correct structure. And I've previewed this already, but compared to social science publications, reports of clinical trials are short, 3,000 words, 2,500 words, 3,500 words, with binding limits on those words, a binding limit on the number of exhibits, sometimes a binding limit on the number of references, in fact, and they follow a consistent structure. And medical journals are often much more prescriptive about that structure and following that structure. Most journals follow consort reporting requirements, which I'll show in a second. This is kind of the standard outline of, I think, most social science or just science research at this point. Your paper is going to have an intro, a method section, a results section, a discussion section. This is not new or radical stuff, but in our experience, medical journals are very prescriptive about what goes where. So a lot of detail about things like randomization and the methods, like I mentioned. Results, talk about results. You introduce all of the numbers, you explain whether they were statistically significant, you give your confidence intervals, you wait until discussion to editorialize about those, completely separate sections. So if you have two primary outcomes, you're going to show the numbers and the graphs about those outcomes, outcome one, then outcome two, then you'll discuss outcomes 1 and 2. It's not outcome 1 plus your thoughts on it, outcome 2 plus your thoughts on it. It's separated out like that. So they're pretty strict. In addition to this, 2 other features that, again, everything already has, but medical journals care a lot about. The abstract is the first thing people are going to read. It's often the only thing people are going to read. And it's framed as a mini paper, and it's, I think, relative to, you should always put a lot of effort into what you write, and shorter things are hard to write. But I think even more than usual, you might want to focus your attention on writing a good abstract. They also care about the title. So if you're doing a randomized controlled trial, the consort requirement is that your title should say that. It should say such and such a topic, a randomized controlled trial. So people know, so that if you're looking at an index of articles in PubMed or something, it's easy to see what's what. this is what that consort, it's really small, thing looks like, but it's again, a checklist, a step-by-step kind of thing of everything that needs to happen within each of those buckets. So within the methods, they want you to talk about the trial design, participants, your intervention, the outcomes, your sample size, all of the randomization stuff that we already talked about. This particular screenshot is actually a worksheet. If you see over on the right, there's a reported on page number with blank lines. This is for when submitting to a journal. Not every journal does this, but JAMA does, and probably some others. They want you not just to do this, but to confirm and tell them on which page you have done each of these things. This is maybe helpful to write your paper. You're at least, you have a formula to work from, but it's, they really care about this process. Yeah.
Especially number one thing is missing data.
That's fascinating. Yeah. So this, don't skimp on doing this. Make sure you cover everything. It's designed as an outline to follow and as a checklist to make sure you've not left anything out. And yeah, it comes from a good place. It's useful, but it's the kind of thing you want to be aware about. Obviously, if you're going to go do this yourself, you should go to the website. You should look at this. There's both the checklist, there's a paper explaining each of these things. Journals have their own, often expanded requirements. They'll explain. There's lots of stuff out there. My goal here is just to kind of highlight a few things that might be unusual from a social science perspective. First, just to go back to this, like their short example. Here's one of the earliest studies that we worked on at JPAL North America, the Oregon Health Insurance Experiment, which is a lottery in Oregon in 2008 to award some people access to the Medicaid program that they were expanding, and other people were not able to access that program. So we used it to evaluate the effect of receiving insurance on a bunch of stuff. I think the study team has written like 12 papers on this particular experiment. These were the first two. The first one was published in the QJE, the Quarterly Journal of Economics. The second one was published in the New England Journal of Medicine. The QJE article is almost 16,000 words. It's got 11 tables and a figure, 44 references, and a slightly non-standard outline. The New England Journal version is just under the 3,500 word requirement. It's got 5 tables. It only has 18 references, and it has introduction, methods, results, discussion. That's the outline. So no deviation. One big caveat to all this is that they all take supplementary appendixes. You can add as much information somewhere else as you want. It's not going to go in the main paper. So even if you can put it somewhere else, you still need to think about this kind of stuff, and you still need room to cover all the stuff that they want you to cover in this small amount of text. I mentioned the abstract before, so write the abstract as a mini paper. These things, this again, I think follows from this kind of audience consideration where abstracts are indexed by search engines like PubMed. They're often the only thing that people read. And if someone like a clinician, a doctor is going to read this, we want them to know the full answer, the full context to what you did. So no cliffhangers in your abstracts. Don't say, this is not the abstract you write for a conference presentation before you've written the paper where you're just trying to get into the conference. You don't actually know what the paper's about. This is a mini paper that has the results. It has the interpretation of those results fully in the abstract. This is again from that healthcare hotspotting paper. This is what the screenshot of PubMed looks like. You can click, you get the full text at the New England Journal. Most people aren't going to do that. If they just read this, you want them to know what's going on. So this is that abstract. It's 4 sections, just like the paper. It's got everything. It's got the point estimate of the primary outcome with its confidence interval, with a quick description of one secondary result, and a conclusion that talks about the significance of it and mentions the clinical trial registration number, funding, all of these things that people might be concerned about. When you go to construct your tables and figures, be aware that journals typically cap the total number of exhibits at 5, and some of those are already spoken for. So figure 1 is going to be that participant flow diagram. Table 1 is often a summary statistics table. That's your balance table, your baseline demographic table, that kind of thing. One thing that I feel like has evolved, at least partially as a result, to get around this restriction in the number of exhibits is you sometimes see kind of hybrid exhibits like this one here, where you've got a table and a figure in one. this works for some journals and not for others. Sometimes that's still two figures, even if you only label it once. Sometimes it's one. Sometimes they're useful, I think, to quickly summarize, a variety of treatment arms in this case, to kind of visually inspect that while also having the detail. This is really a figure with a bunch of labels on it rather than a table and a figure, if you think about it that way. Sometimes the data visualization principles of these are pretty bad. Sometimes they're useful. So, use with caution or exercise your own judgment. Read the journal requirements to see if this will actually help you if you're worried about limits, but that's just something that you see. A couple more things on just analysis norms broadly. And this, I think, follows from all of the standard, best practices in open and transparent science, but you don't want to be selectively reporting outcomes. They want results for all primary and secondary outcomes reported regardless of statistical significance. This typically means in the text, not just in a table, but described. And what's maybe more unusual is that there's often a lot of detail requested about each outcome. So not just a treatment effect coefficient, but you'll often see the mean of the control group, the mean of the treatment group, that treatment effect, a confidence interval, and a p-value all in a sentence. So that's something to be aware of for word count. Also important, I think, to make clear what's pre-specified and what's not. They're not contradicting anything we talked about in the last session as far as the value or the limits of pre-analysis plans, but this is something that journals seem to care a lot about. And so having that clearly marked is helpful. Again, from this healthcare hotspotting study, this is what this looks like in practice. So this is, I'd say, fairly common to how these things kind of look. So this is a bunch of different outcomes. Each row in this table is a different outcome measure. And in fact, we have two regressions represented on each line, or a difference in means and a regression. So there's a control group mean, there's a treatment group mean, there's the unadjusted between group difference, which is essentially a regression result with a regression with no controls and a confidence interval. And then the adjusted between group difference, which is the treatment effect from a regression with controls and a confidence interval for all of our outcomes. So this kind of reading with like means plus a treatment effect plus confidence interval, I think is fairly common. It's certainly more common than the kind of social science thing where you might see, a coefficient and a standard error. You see something like this more often. I mentioned earlier that we didn't pre-specify for this paper our multiple hypothesis testing. So as a result of that, there are no p-values in this table. We put p-values in. They asked us to take them out. We were allowed to discuss, and so it's in the table note and it's in the text, the p-value for that primary outcome, any hospital readmissions, the first one there. But there's no p-values, there's no stars in the table. Now, savvy readers will note that the confidence intervals here encode the exact same information. We were not asked to actually use a multiple hypothesis testing correction of any kind, but I think this is something where they are concerned about overinterpretation or misinterpretation by the audience. And so eliminating that kind of quickly scannable significance column was their way of kind of guarding against the fact that it might be easy to overinterpret, particularly the secondary outcomes in this example. Your mileage may vary as far as this thing goes, but this is just to show the kind of editorial control that was exercised there. And we went back and forth on this a lot. We, kept trying to sneak them into the appendix tables. They had to come out there too. We tried to argue for all of the different things that eventually came out, and that was the way it worked. There's a line or two of text in the paper saying we had no plan for testing multiple comparisons, and so therefore we interpret the primary outcome and everything else is, should be considered exploratory or something. That's what they asked us to put in. And we had no way to, had we, I think, pre-specified even, I don't think they would have, had we had something, we would have been able to lean on that, but we had nothing. And so we kind of had to fall back on what they requested. All right, so last section here, when you go ahead to submit your manuscript for review and hopefully for publication, a couple things to keep in mind. So and this maybe someone else in the audience can shine a light on the relative importance of these things, because this is something where I'm speculating a little bit more from what we've learned. But so you're often asked to submit a cover letter. There's conflicting opinions on the importance of the cover letter. I've seen cover letters that just say, here's our paper, and that's it. I've also heard from other folks that, the cover letter is an opportunity to pitch the paper and explain why the findings are important and relevant to the readers of this journal. Sometimes it's a useful place to provide context for something. Maybe you didn't pre-register, but you did it a day later and you think that should count. You could make your case there. Maybe you're in some weird situation where this is secondary analysis, or you had a preprint, which I'm going to talk about in a sec. You could always use this. You shouldn't give up this opportunity to make your case, but whether it matters, I think, is a matter of some debate. The study type label, you're often asked to explain at this point, is your study a clinical trial? Is it some sort of type of research that you pick from a dropdown? This is the opportunity to kind of revisit that question of, did you think this is a clinical trial? Did you follow all the rules? And to make sure that you label it appropriately. I don't think there's a way to game the system here. And like, if you didn't pre-register, you just declare it not a clinical trial and you get through as observational research or something. Like, that's not right. And I also don't think it works. But if you're in one of these cases where like you're evaluating an intervention that like Medicaid did on its own, and so you registered it, but not on time, but it's a secondary analysis, like that might be something where you think about how to label it, both in their system and in your type. And then last two things, preprints and working papers and embargoes. So I said earlier, this is an evolving area of work. Some journals only want manuscripts if they've not been released as a working paper. They want to be the ones to break the news about your cool study. If you've put it out online already, they don't really see the value in them contributing to getting it out if it's already out there. Some journals have publicly stated, the BMJ, the Lancet, New England Journal of Medicine, JAMA, that they don't penalize studies that are already available as preprints. As long as you say that you did that, that's something to put in your cover letter. Other journals are ambiguous, or I think Health Affairs says they're only interested in stuff that, if it's been out as a preprint, is significantly different than the preprint version. I'll say for our lab, if we know we're targeting a medical journal, we tend not to release it as a working paper. Same thing there's some, this is in flux, it's ambiguous. I would look at your journal, your top target journal, and see what they require. You might want to err on the side of caution and not do a preprint or working paper. The thing that I think most journals still have and do care about are embargoes. So this is once you've submitted the paper, once it's been accepted and before it's been released, they don't want you going out and talking about it or releasing those results, or even necessarily telling folks that it's forthcoming in that journal. They want to be able to, again, be in control of that. Most journals really do care about this one. They typically will allow you to present at conferences, but they might ask that you don't release full versions of the paper, don't have a stack of them on the table when you're presenting, stuff like that. One nice thing though is, or I guess a couple nice things, they publish quickly. A lot of these journals publish weekly, so the time between acceptance and publication is relatively short. So that's nice. And there's usually a pre-release window where there is given access to the media and stuff like that. So if someone does want to write an article about your work, there's an opportunity to do that so that article comes out, the same day that the paper does. There's accommodation for these kinds of things. But if you're working with an implementing partner, someone else on your study who might want to release results to the world as soon as they have them because they're excited about them, this is something to clue them in on and have that be part of the discussion. You're targeting a medical journal, there's rules, things like that. Okay, that's it. I've got some random concluding tips, which is really just planning ahead. I recommend, in addition to the official guidelines, do some tactical reading, find a model article you like, see how they handled these things. And reviewers or people expect some confusion. This is a bit of, as much as people have tried to adapt these to social science, things like that, there's often a place where, you're left scratching your head. What do they mean by this? And, you can always ask questions. You can do your best and that kind of thing. All right, I'll stop talking. We have a resource on our website, forthcoming. That's all the content that I just talked about. And the place to go for these reporting guidelines is equatornetwork.org. There's also a consort website but that one is down. So the Equator Network one is the official spot for all of these different checklists. All right. Thank you guys so much. I think I'm over time, but I'll take questions.